Okay, so we're gonna start Pathoma today. Um, Verse of the day: I can do all this through Him who gives me strength. Philippians 4:13. It's my favorite, one of my favorite verses. I can do all things through Christ who strengthens me, and therefore we shall start. Chapter 1: Growth adaptation, cell injury, and cell death. Growth adaptations. It means that an organ is in homeostasis with the physiologic stress placed on it. An increase, decrease, or change in stress on an organ can result in growth adaptations. Okay, so an organ is in homeostasis with the physiologic stress placed on it. An increase or decrease or change in stress on an organ can result in growth adaptations. And we're going to talk about the types of growth adaptations now. Hyperplasia and hypertrophy. An increase in stress leads to an increase in organ size. Okay. Occurs by an increase in the size, hypertrophy, and or the number, hyperplasia of the cells. Okay. So hyperplasia is an increase in the number of cells, and hypertrophy is an increase in the cell size. Okay. So occurs by an increase in the size, which is hypertrophy, and or number of the cells, which would be hyperplasia. Next, we are talking about hypertrophy involves gene activation, protein synthesis, and production of organelles. Yeah, hypertrophy involves gene activation, protein synthesis, and production of organelles. Okay, hyperplasia involves the production of new cells from stem cells. Hyperplasia and hypertrophy generally occur together, like, for example, uterus during pregnancy. Okay. Permanent cells, permanent tissues like cardiac muscle, skeletal muscle, and the neurons. Um, however, cannot make new cells, and cardiac muscle, skeletal muscle, and nerve cells can only undergo hypertrophy. Okay. For example, cardiac myocytes undergo hypertrophy, not hyperplasia, because cardiac myocyte is a permanent cell. Yeah. For example, cardiac myocytes undergo hypertrophy, not hyperplasia, in response to systemic hypertension. That's why you see left ventricular hypertrophy, never left ventricular hyperplasia, right? So that's it. Um, pathologic hyperplasia, like endometrial hyperplasia, can progress to dysplasia and eventually cancer. Yeah, pathologic hyperplasia, like endometrial hyperplasia, can progress to dysplasia and then cancer. A notable exception is BPH, which does not increase the risk for prostate cancer. So what you need to know here would be okay, so production of organelles right here, production of organelles. That means more mitochondria is needed to make the organ bigger. So there's more cells, there'll be more mitochondria. And that's so the cell can hypertrophy. And the protein synthesis, there'll be more protein synthesis, right? More protein synthesis, so that the cytoskeleton can get bigger, and there'll be more gene activation so that the cell can get bigger. Okay, more gene activation so that the cell can get bigger. And we already said here in the permanent tissues that no stem cells, um, like the cardiac muscle, skeletal muscle, nerve tissue, they don't have stem cells, so the cardiac muscle, skeletal muscle, and nerve tissue cannot make new cells, and these three things can only undergo hypertrophy. Hyperplasia can never happen in these cells, and yes, so the heart can only undergo hypertrophy and never hyperplasia. That's high yield to know. Now, physiologic hyperplasia is normal, like in pregnancy, the uterus, um, it undergoes hyperplasia and hypertrophy, both of them. So something you have to know is that BPH, a notable exception for benign prostatic hyperplasia, is that it does not increase the risk for prostate cancer. Okay, next. Atrophy. So atrophy is a decrease in stress. For example, decreased hormonal stimulation, disuse, or a decreased nutrients / blood supply. And this leads to a decrease in organ size, which is known as atrophy. Atrophy occurs by a decrease in the size and number of cells. Decrease in the size and the number of cells. There's a decrease in cell number, which occurs by apoptosis. And decrease in cell size occurs by ubiquitin proteasome degradation of the cytoskeleton and autophagy of cellular components. In ubiquitin proteasome degradation pathway, the intermediate filaments of the cytoskeleton are tagged with ubiquitin and destroyed by proteasomes. Autophagy of cellular components involves generation of autophagic vacuoles. These vacuoles fuse with lysosomes whose hydrolytic enzymes break down cellular components. Okay, so what you have to know is that ubiquitin is a protein that tags cytoskeleton. Proteasome is inside the cell, and proteasome recognizes ubiquitin So here we said if there's a decrease in cell number, that happens by apoptosis. But if there is a decrease in cell size, that occurs by ubiquitin proteasome degradation pathway. And what that means is, for atrophy to happen, the cytoskeleton has to be broken down. How cytoskeleton breaks down is by the ubiquitin proteasome pathway. Ubiquitin, this green thing, is a protein that gets posted onto the intermediate filaments of a cytoskeleton. So ubiquitin gets tagged onto a intermediate filament, right? It's a part of the cytoskeleton, right? This thing right here, this red thing. So ubiquitin gets tagged onto the intermediate filament of the cytoskeleton, and then proteasome is this other thing over here. Proteasome is something within, it's inside the cell that recognizes the ubiquitin tagged protein, the ubiquitin tagged protein, and then the proteasome trashes these proteins and destroys them. This is how cytoskeleton gets destroyed and atrophy happens. So first you have protein. So for the purposes of understanding, this would be it's a protein, but it's known as intermediate filament. It's something that makes up the cytoskeleton, and this thing ubiquitin is this green thing. This comes onto the intermediate filament, and now we have intermediate filament with a bunch of ubiquitin on it, and then proteasome comes and destroys this thing. See this? See, it's all destroyed. Okay, so that is the ubiquitin proteasome pathway, and that is how atrophy happens. Okay, what is atrophy? It can happen in two ways. It can happen in decrease in cell number, which is apoptosis, and then it can happen in decrease in cell size. And ubiquitin proteasome degradation pathway is how the decrease in cell size happens. And then in ubiquitin proteasome degradation, intermediate filaments of the cytoskeleton are tagged with ubiquitin and destroyed by proteasomes. Remember that. Autophagy of cellular components involves generation of autophagic vacuoles. These vacuoles fuse with lysosomes whose hydrolytic enzymes break down cellular components. Okay, so for the cell to shrink, organelles in a cell need to be consumed. Little vacuoles are created by the cell for the cell to eat its own organelles. These vacuoles fuse with lysosomes, and these lysosomes contain hydrolytic enzymes that will do autophagy of cellular organelles. Okay, so autophagy of cellular components involves generation of autophagic vacuoles. These vacuoles fuse with lysosomes whose hydrolytic enzymes break down cellular components. So basically what happens is the cell makes the vacuoles so that the cell can eventually eat the insides. So those vacuoles fuse with lysosomes whose hydrolytic enzymes break down cellular components. So let's say this entire thing is on the inside of the cell, and this is a vacuole. This is a lysosome which has hydrolytic enzymes in it, which break down unwanted things. So this right here is a vacuole. This is a lysosome. They combine, and the lysosome and the vacuole combine inside the cell, and then the hydrolytic enzymes inside the lysosome eat this vacuole thing, and it degrades and becomes non-existent. So this is how the cell shrinks. The organelle in the cell needs to be consumed. Little vacuoles are created by the cell to eat its own organelles. These vacuoles are created by the cell itself. Lysosome was already there, but then the vacuole joins the lysosome, so the vacuole can die, and so this is the form, like them forming together, and becomes destroyed. The lysosome uses the hydrolytic enzymes to destroy the vacuole and becomes non-existent. Trash. And this is how a cell atrophies. And we already talked about ubiquitin. Okay. So I understand that too. Now, next we are going to go with metaplasia. Very high yield. Well, chapters 1 through 4 are extremely high yield anyway, so you have to know each and every detail. Okay? So, yeah. Metaplasia. Metaplasia is a change in stress on an organ. Yeah, metaplasia is when a change in stress on an organ leads to a change in cell type. This is known as metaplasia. A change in stress on an organ leads to a change in the cell type. Okay, so most commonly involves change of one type of surface epithelium, squamous, columnar, or urothelial, to another. Metaplastic cells are better able to handle the new stress. Barrett esophagus is a classic example. Esophagus is normally lined by non-keratinizing squamous epithelium suited to handle friction of a food bolus. Acid reflux from the stomach causes metaplasia to a non-ciliated mucin-producing columnar cell, better able to handle the stress of an acid. Metaplasia occurs by reprogramming of stem cells, which then produce a new cell type. Metaplasia is reversible, in theory, with removal of this driving stressor. For example, treatment of gastroesophageal reflux may reverse Barrett's esophagus. Under persistent stress, metaplasia can progress to dysplasia and eventually result in cancer. For example, Barrett's esophagus may progress to adenocarcinoma of the esophagus. A notable exception is apocrine metaplasia of the breast, which carries no increased risk for cancer. Okay. So, if there is increased stress on an organ, the organ will respond by changing its cell type. This is because the new cells are better able to handle the stress placed on it. So what happens in Barrett's esophagus is this. Ready? So, Barrett's esophagus. See this. The stomach, then we have the esophagus here. This right here is the lower esophagus. Okay. So acid from the stomach shoots up into the lower esophagus and causes stress, because that's not where acid is supposed to be. Acid is only supposed to be in the stomach. So the acid shoots up into the lower esophagus, and this causes stress, and this will cause the lower esophagus to go from the normal stratified squamous epithelium that the esophagus has to columnar non-ciliated mucinous epithelium. So the take-home point here is that due to the high acid reflux, the lower esophagus epithelium changes from stratified squamous epithelium to columnar non-ciliated mucinous epithelium. Where is the columnar non-ciliated epithelium coming from? It changes, it changes into that from stratified to columnar, because columnar is the normal epithelium in the stomach, and the esophagus thinks, well, dang, I can't take all this with my normal epithelium, so I'm going to change into columnar epithelium so that I can withstand the acid that's shooting up against me. So that's why it changes from stratified squamous epithelium to columnar non-ciliated mucinous epithelium. And this is known as Barrett's esophagus. That's very, very high yield. Barrett's esophagus is an example of metaplasia. Esophagus is normally lined by non-keratinizing squamous epithelium. Right? This is only meant to handle food, friction of food bowls. So it's only this non-keratinizing squamous epithelium is only meant to handle volume of food. Once that food has digested by ECL, that only the stomach can handle that food. Acid reflux in the stomach causes metaplasia to non-ciliated mucin-producing columnar cells, which is better able to handle the stress of acid, right? Okay. And you can see right here, this is what the esophagus normally is supposed to look like, smooth. And you can see right here, it's all, that looks like a rough environment, right? Somewhere where acid would be to withstand. Yeah, that makes sense. So, this is what? This is non-keratinized squamous epithelium. And it converts into columnar, non-ciliated, mucin-producing columnar epithelium. Non-ciliated means there's no little hair. And in this area, it produces mucin columnar cells. Okay. Next. Metaplasia occurs by reprogramming of stem cells, which then produce the new cell type. Which makes sense, right? Because the esophagus is not a heart cell, a neuron, or what's the third one? I believe it's, let's see, skeletal. Yeah, that's what I thought. Cardiac, skeletal, and neuron. Those three are the ones who cannot make new cells. Cannot make new cells because the cardiac, skeletal, and muscle do not have stem cells, so they can regenerate. They cannot make new cells. They undergo hypertrophy only. But here, metaplasia occurs by reprogramming of stem cells, which then produce a new cell type. Hold on, which then? So, like we were saying, the skeletal muscle, neurons, and cardiac muscle, it does not undergo metaplasia. Typically, they don't, because they don't have stem cells like the rest of the body. So therefore, they cannot divide, and they cannot make new cells or switch into anything else. So here, metaplasia, like we've learned it, switches from one cell type to another. Okay, so metaplasia occurs by reprogramming of stem cells, which then produce a new cell type, right? So metaplasia happens where, in the skin, it can happen in the GI system, anywhere that typically is not the neuron, the cardiac cells, um, or the skeletal muscle. So, yes. Here we said that metaplasia is reversible in theory with removal of the driving stressor. For example, treatment of gastroesophageal reflux may reverse Barrett's esophagus, which means that once you reduce acid going into the lower esophagus from the stomach, you can reverse Barrett's esophagus. You can reverse the non-ciliated mucin-producing columnar epithelium into the non-keratinized stratified squamous epithelium. Okay, but you'd have to get rid of the acid first. Okay, so yes, so in theory, metaplasia is reversible. Now, under persistent stress, metaplasia can progress to dysplasia and eventually result in cancer. For example, Barrett's esophagus may progress to adenocarcinoma of the esophagus. Yeah, if you continuously have GERD, the metaplasia will switch into dysplasia, and then that can switch into cancer, specifically adenocarcinoma of the esophagus. A notable exception is apocrine metaplasia of the breast, which carries no increased risk for cancer. So there is this one type of metaplasia that happens in the breast, and that does not cause cancer. Also, fibrocystic changes does increase the risk for breast cancer, but apocrine metaplasia does not increase the risk for breast cancer. That is an exception. You probably should know it because it is an exception. Because most people see metaplasia and be like, "Oh, cancer," but no, it is not. Okay. All right. So that's there. Always remember the exceptions. Okay, so vitamin A deficiency can also result in metaplasia. Vitamin A is necessary for differentiation of specialized epithelial surfaces, such as the conjunctiva covering the eye. In vitamin A deficiency, the thin squamous lining of the conjunctiva undergoes metaplasia into stratified keratinizing squamous epithelium. This change is called keratomalacia. Mesenchymal, also known as connective tissues, can also undergo metaplasia. A classic example is myositis ossificans, in which connective tissue within the muscle changes to bone during healing after trauma. Okay, so here, what you have to know here is vitamin A. So vitamin A is absolutely important for differentiation of the conjunctiva covering of the eye. So I would think it was like the eye maturing, like for sight, for the betterment of the eyes. Vitamin A is necessary. That's how I think of it. Um, yeah, in vitamin A deficiency, that the lining of the eye, the thin squamous lining of the eye, the conjunctiva, undergoes metaplasia into stratified keratinizing squamous epithelium. This change is called keratomalacia, which means thickening of conjunctiva due to the vitamin A deficiency. So, when vitamin A deficiency, the thin squamous lining of the conjunctiva undergoes metaplasia into stratified keratinized squamous epithelium. So it goes from Okay, so in this text in Pathoma, I think it's a 2021 version, but basically it says in vitamin A deficiency, the thin squamous lining of the conjunctiva undergoes metaplasia into stratified keratinizing squamous epithelium. But in my text, it says that in vitamin A deficiency, the goblet cells and columnar epithelium of the conjunctiva undergoes metaplasia into keratinizing squamous epithelium. So I'm going to go with columnar. I'm going to say that the lining of the eye, the conjunctiva, is made up of goblet cells and columnar epithelium. And I also looked it up on ChatGPT, and then it says the normal epithelium lining of the conjunctiva is a non-keratinized stratified columnar epithelium that contains goblet cells. When I asked ChatGPT what is the epithelial lining of the conjunctiva, and it says goblet cell, so I'm going to say maybe it's an error in the text online. But in my book, which is back in 2016, it says the vitamin A deficiency. It is the change from the goblet cells and columnar epithelium of the conjunctiva to the keratinizing squamous epithelium, and that is the metaplasia. So it goes from goblet cell and columnar epithelium to keratinizing squamous epithelium, and that is the metaplasia in vitamin A deficiency. Dry eyes, also known as xerophthalmia, mm, can lead to destruction of the cornea, um, known as keratomalacia, which is thickening of the conjunctiva due to vitamin A deficiency, and this can cause blindness. I'll show you a picture. Keratomalacia. So this right here, this is keratomalacia. You see the thickening of the conjunctiva? This is what happens in vitamin A deficiency. Okay. Now, um, there's something else you need to know about vitamin A deficiency. Vitamin A also helps immune. It also helps the immune system mature. When patients get 1517 translocation, they develop acute promyelocytic leukemia. When 1517 translocation occurs, it disrupts vitamin A receptor. Disruption of vitamin A receptor causes the cells to remain trapped in the blast stage, causing acute promyelocytic leukemia. The treatment for acute promyelocytic leukemia is ATRA, which binds mutated receptor, which allows cells to mature to become neutrophils. So you have to understand that vitamin A also helps in the maturity of the immune system. When a patient gets the 1517 translocation, they develop acute promyelocytic leukemia. When 1517 translocation occurs, it disrupts vitamin A receptor. Disruption of vitamin A receptor causes cells to remain trapped in the blast stage, causing acute promyelocytic leukemia. Treatment for acute promyelocytic leukemia is ATRA, which binds mutated receptor, which allows cells to mature to become neutrophils. Okay. So know that vitamin A helps in maturing the immune system. 1517 translocation causes the cancer known as acute promyelocytic leukemia. And this causes cells to remain trapped in the baby stage. And then you give them ATRA, all trans retinoic acid, which helps bind the mutated vitamin A receptor and for the cells to mature from the blast stage to become neutrophils. Otherwise, there would be so many blasts, and that would be acute promyelocytic leukemia, which is what 1517 translocation. So all trans-retinoic acid induces differentiation of promyelocytes into mature white cells. Yep. So just remember that some of the symptoms of acute promyelocytic leukemia is fatigue, weakness, infections, easy bruising or bleeding due to low platelets, and coagulopathy. Bleeding may be severe, risk of DIC. We're going to get into that later. Disseminated intravascular coagulation is high in acute promyelocytic leukemia. So here the problem is, the WBC, white blood cells are trapped in the baby stage. But then you give the vitamin A to mature them into neutrophils. So the treatment is known as ATRA, A-T-R-A. Okay, next we have mesenchymal connective tissue. Mesenchymal, also known as connective tissues, can undergo metaplasia. Connective tissue would be like blood, ligaments. So connective tissue is one of the four main types of tissues in the body, alongside epithelial, muscle, and nervous tissue. Its main job is to support, connect, and protect other tissues and organs. So the connective tissue would be tendons, ligaments, blood, bone, cartilage, lymph. It's basically things that hold other things together, like it cushions organs, stores fat, and hold muscles together. Those are connective tissues. Okay, so mesenchymal connective tissues, also known as connective tissues, can also undergo metaplasia. A classic example is myositis ossificans, in which connective tissue within the muscle changes to bone during healing after trauma. So, myositis ossificans. Myositis ossificans. So, here, what's the problem here? The problem is, oopsies. Okay. In which the connective tissue within the muscle changes to bone. Okay, maybe that's not a good picture. Basically, they're saying whatever's inside the muscle, it becomes bone, right? Let's maybe this is a good picture. And it is. So, this right here, that's supposed to be muscle, right? It becomes bone. So, inflammation of the skeletal muscle results in metaplastic production of bone within skeletal muscle. Skeletal muscle inflamed due to trauma, and when skeletal muscle is healing, some muscle is converted to bone. So there was an actress who actually had this disorder. Um, I don't know. Let's see, I don't know if you know her, but she was apparently diagnosed with this. So, and I think I saw her like parts of her face like changing because of this disease. But yeah, she came out and she was talking about it, how it was really hard for her. It happens after trauma. The muscle becomes bone. But I remember her face, and I remember her talking about it, and basically her face was like somewhat paralyzed. Um, and I looked it up, and this is what it was: myositis ossificans. So basically, she had like a frozen smile. It was hard for her to move, and yeah. So remember Samantha if you watch her movies, and this is the disease that she has. So yes. Next, we will talk about dysplasia. Okay. So dysplasia is disordered cellular growth. Most often refers to proliferation of precancerous cells. For example, cervical intraepithelial neoplasia, also known as CIN, represents dysplasia and is a precursor to cervical cancer. Often arises from long-standing pathologic hyperplasia, endometrial hyperplasia, or metaplasia, like Barrett's esophagus. Dysplasia is reversible in theory with alleviation of inciting stress. If stress persists, dysplasia progresses to carcinoma, which is irreversible. Okay, so what they're saying is dysplasia is disordered cell growth, right? So let's see the type of dysplasia. This is a better picture. You see how the cell here is normal, it's uniform, right? And then over here you see like irregular, um, like there's a part that's normal, there's a part this part that is irregular, abnormal. You see large and small nuclei. You see the nucleus trying to divide here. Um, yeah, so this is like the precancerous stage right here, and this is full blown cancer. So this is still just reversible. Cancer is not. cancer is irreversible. Okay, so dysplasia progresses to cancer. Okay, now, yeah, disordered cell growth, that's dysplasia. Dysplasia most often refers to proliferation of precancerous cells. For example, cervical intraepithelial neoplasia represent dysplasia and is a precursor to cervical cancer. So sin is this. Sin dysplasia. So cervical cancer, okay, this is normal, right? And this is full-blown cervical cancer, and these are the stages right before that. So right before you get the cancer. So this is where cervical cancer happens. Cervical cancer is most commonly caused by HPV, which is human papillomavirus. There is a vaccine that protects against cervical cancer. Like, it's a vaccine for HPV, so they give it in the teenage years. HPV vaccine given. Yeah, starts as early as 9 and recommended for 11 and 12. So right before they turn into their teenage years, right? So 6 and 12 months. So the first dose is given around 11. Then the second and third doses are given 6 to 12 months after. The second dose is given 6 to 12 months after the first, and it's also a third dose is given for those 15 years and older. Though weakened immune system, 3 dose usually recommended. Yeah, so I remember the doctor telling me it was like 3 doses for the HPV vaccine. Yeah, so it protects against the cervical cancer. So let's see. So this is where the cervical cancer happens. So this is normal, and this would be low-grade intraepithelial neoplasia, and this would be high-grade intraepithelial neoplasia, and this will be cancer, cervical cancer. Even up until this stage, it would be considered reversible, right? This is still dysplasia, this 1 and 2. Okay, and this would be irreversible. Okay, so dysplasia often arises from long-standing pathologic hyperplasia. So here there's the name pathologic, which is it's differentiated from physiologic hyperplasia. Physiologic hyperplasia would be pregnancy, like the uterus during pregnancy. That's normal, right? the uterus will hypertrophy and undergo hyperplasia in pregnancy, which is a normal part of life, right? Now here, they're saying dysplasia is from pathologic hyperplasia. Pathologic means an abnormality. It's never supposed to happen. So pathologic hyperplasia. So dysplasia comes from a long-standing stressor. In this case, endometrial hyperplasia would be due to ongoing estrogen. So let's see, endometrial hyperplasia. See this, endometrial hyperplasia is abnormal thickening of the endometrial lining primarily due to prolonged estrogen stimulation unopposed by progesterone, right? So these are the reasons. Right? Obesity is one of them. Chronic anovulation, like in PCOS. Okay. Estrogen secreting tumors, granulosa cell tumor, tamoxifen use. Okay, we'll get into that later, but I'm just going to give the idea. Okay. Now, so ongoing estrogen will cause endometrial hyperplasia, and then that will, that will lead to endometrial cancer. Okay. And metaplasia, we talked about this. What was it? Metaplasia is due to acid reflux, chronic acid reflux into the lower esophagus. That will change the normal stratified squamous epithelium. That will change the normal stratified squamous epithelium to columnar. Specifically, it will go from non-keratinizing squamous epithelium to non-ciliated mucin-producing columnar epithelium. So if you make the stress go away, the dysplasia is reversible. If the stress persists, like acid reflux persists in Barrett's esophagus, then it will turn into carcinoma, which specifically would be adenocarcinoma of the esophagus, right? Also, the epithelium in the esophagus would be non-keratinized squamous epithelium, which means it lacks keratin. And non-keratinizing epithelium is found on wet surfaces like the lower esophagus, oral cavity, the vagina, and the anal canal. It's so that it's not hard. Like, it's a way to remember that it's not hard. So it's always non-keratinized is always found on wet surfaces, mainly on the inside, right, inside of the body. On our skin, it's keratinized, which means it has keratin. The skin has keratin in it, and it has to be to withstand the external, like the environment. So think of it that way. That's why it has keratin in it, and it's hard. But on the inside, in places like the esophagus, your mouth, it's usually like the wet surfaces that are more delicate, I would say, has to be non-keratinized. Okay, next. Next, we're going to go into aplasia and hypoplasia. Okay, aplasia is a failure of cell production during embryogenesis. For example, this would be unilateral renal agenesis. Hypoplasia is a decrease in cell production during embryogenesis, resulting in a relatively small organ. For example, a streak ovary in Turner syndrome. Okay, aplasia is when something like an organ does not form properly during embryogenesis, during when the baby is being formed. It's a failure of cell production. Yeah. So unilateral renal agenesis, some people are born without a kidney. That's what happens. So that is an example of aplasia, if somebody doesn't have a kidney. Now, hypoplasia is a decrease in cell production during embryogenesis, resulting in a small organ. Like, for example, in Turner syndrome, you have streak ovary. So this would be like this. You see how this is a normal ovary? It's big enough, it's as large as a normal ovary, but here it's a small, relatively it's much smaller. The second ovary is much smaller in size. This would be a streak ovary seen in Turner syndrome. This is Turner syndrome. We're going to get into that when we do genetics, but quickly, that is what Turner syndrome is. See this, rudimentary ovaries. That means like a small ovary. Okay. Alright, so let's see. That's there. So aplasia is a failure of cell production. Hypoplasia is a decrease in cell production. Okay. Alright, so this right here, this is an example of the left ventricle that hypertrophied from systemic hypertension, right? Okay. And then this right here will be Barrett's esophagus. So I'll show you what a normal esophagus looks like. Okay. So right here you have a picture of a normal esophagus. You see this is a normal esophagus. Normal esophageal squamous mucosa at the top. You can see this would be normal stratified squamous at the top, which would be non-keratinized. Okay, and over here you can see the same image that has converted to columnar epithelium, so that the esophagus can withstand the acid. So it changes to the stomach epithelium. You can see here, this is gallbladder cells right here, right? I mean, it has switched. See those gallbladder cells, and then right here, this is squamous epithelium. This is the normal epithelium of the esophagus. But right here, you can see this is the dysplasia. Well, metaplasia. It'll be metaplasia and then dysplasia. But Barrett's esophagus is a metaplasia. Okay, so this metaplasia of the esophagus. Okay, now next we have a picture of the heart in the text. See this? So we covered this Barrett's esophagus. Now this right here, this is left ventricle hypertrophy. So that's what this is. Left ventricle hypertrophy due to aortic stenosis or hypertension, right? And then if you look at the image, hypertrophic myofibers, they have larger nuclei compared to normal myofibers. Right? So this is normal image of the heart, and then this is abnormal once the nuclei have hypertrophied. Okay, so that's that. Next we have, oops. Next, we have cellular injury. So we're on cellular injury now. Cellular injury occurs when a stress exceeds a cell's ability to adapt. The likelihood of injury depends on the type of stress, its severity, and the type of cell affected. Neurons are highly susceptible to ischemic injury, whereas skeletal muscle is relatively more resistant. Slowly developing ischemia, for example, renal artery atherosclerosis, results in atrophy, whereas acute ischemia results in renal artery embolus. Sorry, result. Okay, slowly developing ischemia, um, for example, renal artery atherosclerosis results in atrophy, whereas acute ischemia, like seen in renal artery embolus, results in injury. Common causes of cellular injury include inflammation, nutritional deficiency or excess, hypoxia, trauma, or genetic mutations. So, cellular injury occurs when stress exceeds its ability to adapt to the changes placed on it. Neurons are very susceptible to ischemic injury, whereas skeletal muscle is not. Um, Slowly developing ischemia will result in atrophy, like seen in renal artery atherosclerosis. So in renal artery atherosclerosis, plaques build up, and that will eventually lead to less blood flow in the renal artery, and that will cause atrophy. Um, but in ischemia, it's like the blood flow is suddenly cut off due to an embolus stuck in the renal artery. This will result in injury. Common causes of cellular injury include inflammation, nutritional deficiency or excess, hypoxia, trauma, or genetic mutations. Okay. Next, we have hypoxia. Hypoxia. Okay. Excuse me. Stop. Okay. So hypoxia is low oxygen delivery to the tissue. It is an important cause of cellular injury. Hypoxia is low oxygen delivery to the tissue. Hypoxia is low oxygen delivery to the tissue. Hypoxia is an important cause of cellular injury. Oxygen is the final electron acceptor in the electron transport chain of oxidative phosphorylation. Decreased oxygen impairs oxidative phosphorylation, resulting in decreased ATP production. Lack of ATP leads to cellular injury. Causes of hypoxia include ischemia, hypoxemia, and decreased oxygen carrying capacity of the blood. Ischemia is decreased blood flow through an organ. Ischemia arises with decreased arterial perfusion, like seen in atherosclerosis, or decreased venous drainage, like seen in Budd-Chiari syndrome, or ischemia So shock is generalized hypotension resulting in poor tissue perfusion. So what they're saying is shock, Budd-Chiari syndrome, and atherosclerosis all result in ischemia, and ischemia is one of the reasons of hypoxia. Yeah. So and then next we have hypoxemia, which is a low partial pressure of oxygen in the blood. Here, PaO2 would be less than 60 mmHg, and SaO2 would be less than 90. Arises with high altitude. Decreased barometric pressure results in decreased PaO2. Hyperventilation. Increased PaCO2 results in decreased PaO2. Diffusion effect. PaO2 is not able to push as much oxygen into the blood due to a thicker diffusion barrier, like in interstitial pulmonary fibrosis. VQ mismatch. Blood bypasses oxygenated lung. So hypoxia is when there's low O2, and that results in low ATP, and low ATP will cause cellular injury. Oxidative phosphorylation is how the body makes ATP. So we said oxygen is the final electron acceptor in the electron transfer chain of oxidative phosphorylation. So oxidative phosphorylation is how the body makes ATP. And so if we have decreased oxygen, that's going to decrease ATP. And if you don't have ATP, you don't have energy, and this will lead to cellular injury. Next, we talked about ischemia. Ischemia is one of the reasons why somebody would get hypoxia, and there's 3 reasons for ischemia. When you have decreased arterial perfusion, which is atherosclerosis. So atherosclerosis is this. Okay, so atherosclerosis. So this is a normal artery, and this is atherosclerosis. So this is fat buildup, and blood cannot get through. So there is less blood going to the organs, and this is what causes ischemia. And this, if there's not enough blood going to the tissues, what is in blood? Oxygen. Then, if you don't have oxygen going, you get hypoxia. Okay, now next one, another reason for ischemia is Budd-Chiari syndrome. This is Budd-Chiari syndrome right here. Okay, so what this is the it's a blockage of the hepatic vein. It's the blockage of the hepatic vein. So right here is blocked, and so you have decreased venous drainage. So when the hepatic vein is blocked, like the blood is backed up into the liver, and the blood can't go, leave the veins, so there's no blood flow, and you get ischemia. The most common reason somebody would get Budd-Chiari syndrome is because of polycythemia vera. Okay. Next, shock. Shock is, let's see if Google can tell you, give me a good picture of shock. So shock is, these are symptoms of shock, and that happens when you have low BP because there's not enough blood going to the tissues. So yeah, that is the third reason for ischemia, and that is why somebody would get hypoxia. Okay, next. The second cause of hypoxia is hypoxemia. Hypoxemia is when there is low partial pressure. When there is a low partial pressure of oxygen in the blood. This arises so here we talked about high altitude causes hypoxemia. Decreased barometric pressure results in decreased PaO2. So barometric pressure is the atmospheric pressure, which is the pressure exerted by the weight of the air in the Earth's atmosphere. So it's, I think of it as the air, the weight of the air in the Earth's atmosphere. So when you go higher, like on a mountain at like higher altitudes, the barometric pressure drops because there's less air above you, which means less oxygen, and this is what causes hypoxemia. So barometric pressure, known as atmospheric pressure, is the pressure exerted by the weight of the air in the Earth's atmosphere. So there's less air, right, as you go out into the solar system, right? So when you go out into the mountain, you're closer to the solar system, right? Than you are like on the road. So so you're closer to the solar system, which means that you have less air, because that's why you need oxygen when you go into the solar system. So I'm trying to think of the way I remember things like this. So at higher altitudes, you need oxygen, a tank. So then, like when you go to like an astronaut, they need an oxygen tank. So think of it as you're going to a mountain. You're closer to the solar system, and you have less the air there because you're closer to the solar system. So you get hypoxia. Your barometric pressure drops because there's less air above you, which means less oxygen, which is why you get hypoxemia. And P large AO2 is oxygen pressure in the alveoli, and P small AO2 is oxygen pressure in the arterial blood. Okay, so in hypoventilation, P large AO2 is decreased. So in hypoventilation, there is increased P large A CO2 and decrease in P large AO2. So in hypoventilation, you're not breathing properly, right? Hypoventilation, it's a decreased respiratory rate. Hypoventilation. So this is the decreased Okay. So there's a decreased respiratory rate in hyperventilation. Um, you're breathing less, right? Um, the normal respiratory rate is 12 to 18 breaths per minute. So hyperventilation would be under 12. Um, so then what happens is CO2 builds up in the body because you breathe out CO2, right? And normally you breathe out CO2 and you breathe in oxygen. So if you're not breathing properly, you're not breathing properly if your respiratory rate is under 12, you cannot breathe out CO2. So that CO2 builds up in your lungs, and that is hyperventilation. So you're going to have an increase in PaCO2 and a decrease in P large AO2. P large AO2 is the oxygen pressure in the alveoli. Yeah, because if you're not able to breathe in, um, if you're not able to breathe in, how are you going to get oxygen to your um, alveoli? Okay, so next we have diffusion. Diffusion defect. PRJO2 is not able to push as much oxygen into the blood due to a thicker diffusion barrier. So interstitial pulmonary fibrosis is when there's fibrosis in the lungs. So you're not able to um, push oxygen into the alveoli. Wait, what? PO2 not able to push as much oxygen into the blood. No, that's wrong. PO2, you're not able to push as much oxygen into the blood due to thicker barrier. Okay, PaO2 is the amount of oxygen that's in your. So, what I meant to say was that I believe it's saying oxygen in the alveoli is not able to push oxygen to the aorta due to fibrosis. So oxygen can't get out to the rest of the body because blood can't flow out properly from the lungs to the heart, to the rest of the body because of the fibrosis in the lungs. Okay. A VQ mismatch. Blood bypasses oxygenated lung or oxygenated air cannot reach the blood. So here, what they're saying is VQ mismatch is ventilation perfusion mismatch. Ventilation is the amount of air that reaches the alveoli. Perfusion is the amount of blood that reaches the alveoli. If either ventilation or perfusion is off, um, that is known as VQ mismatch. Ventilation and perfusion have to be the same. They should match. So if either the air or the amount of air that gets to the lungs or the amount of blood that reaches the lungs, it's not the same in relation to each other, then there will be a balance. There will be an imbalance. So this is a VQ mismatch. So here the same blood bypasses the oxygenated lung. Okay, yeah, right. So the blood doesn't reach the lung; it goes somewhere else. For example, like in a right to left shunt, or oxygen air cannot reach blood. Ventilation problem. Yeah, or the oxygen air doesn't reach the lungs. So then, like an atelectasis. Yep. Okay. Okay. So mismatch is when blood skips the lungs, like in right to left shunt, or oxygenated air from the lungs can't go from the lungs to the heart to the rest of the body, like in atelectasis, which is atelectasis is a collapsed lung, so no gas exchange is happening in that collapsed lung. Okay. Next, we have decreased O2 carrying capacity. Decreased oxygen carrying capacity arises with hemoglobin loss or dysfunction. Examples include anemia and carbon monoxide poisoning. So, another reason for hypoxia is um, decreased oxygen capacity, decreased oxygen carrying capacity, um, because of hemoglobin loss or defect. And example of this include anemia or carbon monoxide poisoning. So anemia, you have PaO2 normal, P small aO2, which is oxygen pressure in the arterial blood. That's normal. And the SaO2, which is the saturation of hemoglobin, saturation of So in anemia, PaO2 is normal because there is no issue to squeeze oxygen into the blood um, or lungs. Yeah, PaO2 is normal because there's no issue to squeeze oxygen. So this is P small a, which is the pressure, which is the oxygen pressure in the arterial blood. So it's the pressure in the arteries slash aorta. So basically, um, they don't have, you know, there's no issue to put blood from the arteries into um, into the lungs or the tissues. Yeah, so PaO2 is normal there. SaO2 is also normal because um, each RBC has 4 HB inside the RBC, and each of those HBs will have an O2 attached to the hemoglobin. An RBC carries 4 hemoglobins and 4 oxygens, right? So in anemia, anemia is a overall decrease in RBC mass. But whatever RBCs there are, all the hemoglobin in there, which is the 4 hemoglobins in there, are completely bound by oxygen. SaO2 is a measure of how much oxygen is saturated to the hemoglobin. I'll repeat it. So, anemia is defined as a decrease in RBC mass. The PaO2 and the the PaO2 and SaO2 are both normal. PaO2 is normal because what is PaO2? It is the oxygen pressure in the arterial blood. So what that means is it's the amount of oxygen that's in the arteries. Um, and it's normal in anemia because PaO2, because there is no issue to squeeze oxygen into the blood or lungs in anemia. The problem is that there is not enough red blood cells. Okay, so in SaO2, what is SaO2? SaO2 is the percentage of oxygen saturated to hemoglobin. Okay, so it's amount of oxygen attached to the hemoglobin, and each RBC has 4 hemoglobin inside of it, and each of those hemoglobin will have an oxygen attached to it. So an RBC will have 4 hemoglobin and 4 oxygens. Okay, so what in anemia, whatever red blood cells there are, all of the hemoglobin in there will be bound by oxygen. All the hemoglobin in RBC is attached to an oxygen. So the hemoglobin in the RBC is completely saturated. So that's why SaO2 is normal in anemia. Anemia has a decreased RBC mass, so there is a decrease in overall oxygen. So there will be low, so the oxygen will be low that goes to the tissues in anemia. Okay, carbon dioxide. What? Carbon dioxide poisoning. Carbon monoxide binds hemoglobin more avidly than oxygen. So here PaO2 would be normal because there's no issue squeezing oxygen into the blood and lungs from the arteries, but there is an issue with how much hemoglobin is being saturated in the RBCs. So normally oxygen goes and binds to the hemoglobin, but if carbon monoxide enters your body, carbon monoxide is going to beat oxygen to the hemoglobin and bind the hemoglobin faster than oxygen ever could. So that is why the saturation in carbon monoxide poisoning will be low. So that's why SaO2 is decreased in carbon monoxide poisoning and PaO2 is normal. Okay, so carbon monoxide poisoning exposure includes smoke from fires and exhaust from cars or gas heaters. Smoke from fires or exhaust from cars or gas heaters. That's where carbon monoxide can leak from. Classic findings of carbon monoxide is cherry red appearance of the skin. Early sign of exposure is headache. Remember that. Somebody comes with a headache, you want to think carbon monoxide poisoning. Significant exposure leads to coma and death. Okay, methemoglobinemia. This is when these two pictures we already talked about in the previous lecture. Okay. So methemoglobinemia. This is when iron in the heme is oxidized to Fe3+, which cannot bind oxygen. PaO2 would be normal. SaO2 would be decreased. This is seen with oxidant stress like sulfide nitrate drugs or newborns. Classic findings is cyanosis with chocolate covered Okay, I think it was chocolate covered blood, but it's chocolate colored blood. Treatment is IV methylene blue, which helps reduce Fe2 plus back to Fe, which helps reduce Fe3 plus back to Fe2 plus. That's a typo on the text. Okay, make sure you change it. Which helps reduce Fe3 plus back to Fe2 plus. It's supposed to be Fe2 plus. It's never supposed to be Fe3 plus. Okay. So what's the problem here? Iron in heme is oxidized to Fe3 plus, which cannot bind oxygen. So there's heme. Okay, hemoglobin. Um, there's iron in the hemoglobin. Um, the iron is oxidized to Fe3 plus, so iron becomes Fe3 plus, and the problem here is that oxygen cannot go and bind to that Fe3 plus, right? So what happens? Again, saturation would be decreased because oxygen cannot go and bind that Fe3 plus. Because it's because oxygen is supposed to go and bind heme, right? But that part of heme is messed up, so it cannot, because the messed up part is Fe3 plus, so oxygen cannot bind Fe3 plus, which would decrease the SaO2. So the saturation of hemoglobin is decreased in methemoglobinemia. PaO2 is normal. Okay, and methemoglobinemia is seen with oxidant stress, like in sulfide nitrate drugs or in newborns. Classic finding is cyanosis with chocolate-covered blood. Okay, you read it as chocolate-colored blood because the blood will actually be like brownish in chocolate. But that's the only way I can remember it. Chocolate-covered blood. Okay, treatment is IV methylene blue, which converts Fe3 plus back into Fe2 plus. Okay, that's it. So to make it more clear, heme is made up of protoporphyrin and ferrous iron, which is Fe2 plus. So this is the formula. Heme is made up protoporphyrin and Fe2 plus. So in methemoglobinemia, okay, normally what happens is oxygen goes and binds to heme, right? To the heme. In methemoglobinemia, what happens is oxygen tries to bind to heme, but it can't because the component of heme that make like the the iron component of heme that makes it up normally is damaged. It is Fe3 plus instead of Fe2 plus. So oxygen cannot come and bind heme. So then the person gets chocolate covered blood. Meth. See this? This is the methemoglobinemia, and this is a normal patient. See how it's brown, like chocolate? So here we have reversible and irreversible cellular injury. Hypoxia impairs oxidative phosphorylation resulting in decreased ATP. Low ATP disrupts key cellular functions including sodium-potassium pump, resulting in sodium and water buildup in the cell, calcium pump, resulting in calcium buildup in the cytosol of the cell, aerobic glycolysis, resulting in a switch to aerobic glycolysis, resulting in a switch to anaerobic glycolysis. Lactic acid buildup results in low pH, which denatures proteins and precipitates DNA. The initial phase of injury is reversible. The hallmark of reversible injury is cellular swelling. Then, so cytosol swelling results in loss of microvilli and membrane blubbing. Swelling of the rough endoplasmic reticulum results in dissociation of ribosomes and decreased protein synthesis. Eventually, the damage becomes irreversible. The hallmark of irreversible injury is membrane damage. Plasma membrane damage results in cytosolic enzymes leaking into the serum, like cardiac troponin, and additional calcium entering into the cell. Mitochondrial membrane damage results in loss of electron transport chain, inner mitochondrial membrane, cytochrome C leaking into the cytosol, which activates apoptosis, and lysosome membrane damage results in hydrolytic enzymes leaking into the cytosol, which in turn are activated by the high intracellular calcium. Okay, so hypoxia impairs oxidative phosphorylation, resulting in low ATP. So when someone's hypoxic, this messes up the way that their body makes ATP. So when you have a hypoxia, you have low ATP. And we have low ATP, the sodium potassium pump cannot work, the calcium pump cannot work, and aerobic glycolysis cannot work. So for sodium potassium pump, if that fails, you'll have high sodium and water building up in the cell. So the job of the sodium potassium pump normally is to push sodium out of the cell. So if the sodium potassium pump fails, then the sodium cannot leave the cell and will build up inside the cell, and wherever sodium goes, water follows. So sodium and water builds up in the cell. That's why you have this statement here, right here. Okay, so next we have the calcium pump failure, and if the calcium pump fails, then calcium builds up in the cytosol of the cell. Right here. So calcium will build up right here, cytosol. So the cytosol normally wants to have very low calcium in it. So the goal is to send calcium out of the cell. But here we have calcium buildup inside the cell, specifically the cytosol. And when you have that, the calcium activates enzymes in the cell, which is bad for the cell. The third point we have here is swelling of the wrong one. Aerobic glycolysis cannot happen. So then aerobic glycolysis switches to anaerobic glycolysis. And in anaerobic glycolysis, you have lactic acid building up. If your acid goes up, the pH will be low. And if, the pH will be low, like closer to 1. And so when that happens, we have too much acid that will denature the protein and precipitate DNA. So anaerobic glycolysis doesn't make ATP, so it doesn't make ATP. So there will be increased lactic acid and decreased pH in the cell, and DNA becomes invisible. And the very first stage of cell injury is reversible. The hallmark of reversible injury is cellular swelling. So if a cell swells, that means that the damage can be undone. The cytosol swelling, right? The cytosol swelling results in loss of microvilli and membrane blubbing. Membrane blubbing is due to the water coming into the cell. This is membrane blubbing right here. Okay. So when the cytosol swells, this results in loss of microvilli and membrane blubbing. Membrane blubbing is when the plasma membrane forms bubbly protrusions. So when the cytosol swells, you get membrane blubbing. So that membrane blubbing is when the plasma membrane forms little bubbles on the surface of the cell. Okay. And membrane building. Okay. And then swelling. Then the second thing that happens is, the second thing that happens in reversible cell injury is a swelling of the rough ER, which causes ribosomes to pop off, so then there will be decreased protein synthesis. And this is still reversible cell injury. Eventually, the damage becomes irreversible. The hallmark of irreversible injury is membrane damage. For example, troponin leaking out into the blood tells you the cardiac membrane is damaged, and troponin leaks out. This will be irreversible damage. So plasma membrane damage results in cytosolic enzymes leaking into the serum, like cardiac troponin, and then additional calcium entering into the cell. Because the membrane is damaged, so calcium can rush into the cell. Number 2, mitochondrial damage results in loss of electron transport chain, which is located on the inner mitochondrial membrane. And then mitochondrial membrane damage causes cytochrome C to leak out into the cytosol. This would activate apoptosis. So cytochrome C will activate apoptosis. Lysosome membrane damage results in hydrolytic enzymes leaking into the cytosol, which in turn are activated by the high intracellular calcium. So what they're saying is mitochondrial membrane damage mitochondrial membrane damage. So basically if the mitochondria is damaged, this will mess up the electron transport chain, because the ETC, which is electron transport chain, that ETC is located on the inner mitochondrial membrane. So then, of course, if the mitochondria is damaged, then things inside the mitochondria will not work. So the ETC will not work. And then cytochrome C leaking into the cytosol will activate apoptosis. So cytochrome C is in the mitochondria, and if there is mitochondrial damage, cytochrome C will leak out into the cytosol and activate apoptosis. Yeah, so the mitochondria has the cytochrome C, and if there's mitochondrial membrane damage, the cytochrome C will leak out into the cytosol and activate apoptosis. So lysosome membrane damage results in hydrolytic enzymes leaking into the cytosol. Yeah, lysosome membrane damage results in hydrolytic enzymes leaking into the cytosol. So the lysosome membrane damage results in hydrolytic enzymes leaking into the cytosol, which in turn are activated by the high intracellular calcium. So here we have the mitochondria membrane damage, so then cytochrome C will leak out into the cytosol, which is right here, and so let's say this right here is the mitochondria. This membrane damage, this red thing, is a mitochondria. Let's say that's what this is, and so that will leak out. Like, let's say there is a membrane damage in the mitochondria. It will leak out. The cytochrome C will leak out into the cytosol, and then remember, there's already high calcium here because of the plasma membrane damage. And so the high calcium will activate lysosomes membrane to also be damaged. Let's say this is a lysosome, and so the high calcium that's in the cytosol will make this lysosome, the lysosome membrane damage to happen, and then the lysosome naturally has lytic enzymes inside of it. They will leak out and kill the entire cell. So lysosome enzymes digest cell. These lysosome enzymes are activated by increased calcium. Okay. The end result of irreversible injury is cell death. So eventually the cell will die, aka undergo apoptosis. Okay, so that's there. Um, all this we'll get back to. It's in the next section. Okay. Here we are talking about cell death. So here's the morphologic hallmark of cell death is loss of the nucleus, which occurs by nuclear condensation, which is known as pycnosis. Then you have fragmentation, which is known as karyorrhexis, and dissolution of the nucleus, which is known as karyolysis. The two mechanisms of cell death are necrosis and apoptosis. So pycnosis, the nucleus shrinks down to a dot. Karyorrhexis, the nucleus breaks up into big pieces. Karyolysis, pieces of the nucleus is broken down into basic building blocks. And then next we have necrosis. Death of large groups of cells followed by acute inflammation. Necrosis is due to some underlying pathologic process, never physiologic. Necrosis is divided into several types based on gross features. So remember we talked about necrosis is something from the outside that causes destruction of the tissue. Apoptosis is cellular suicide, and tissue does not react. So basically, in necrosis, there's always going to be acute inflammation, but in apoptosis, there is never acute inflammation. And what is acute inflammation? It is increased neutrophils coming in after a heart attack to secure the wound, right? So, yep. And necrosis is divided into several types based on gross features. The gross patterns of necrosis. The first one is coagulative necrosis, which is like when the necrotic tissue that remains firm. And coagulative necrosis is necrotic tissue that remains firm. The cell shape and organ structure are preserved by coagulation of proteins, but the nucleus disappears. Characteristic of ischemic infarction of any organ except the brain. Area of infarcted tissue is often wedge-shaped, pointing to focus of vascular occlusion and pale. Red infarction arises if blood re-enters a loosely organized tissue, like in pulmonary or testicular infarction.